as with any procedure, as with anything that you do, there are always indications and contraindications, and that's true for RSI. Here's just a list of some of the indications, and I would expect everyone to review this full list. We think of indications of when a patient can't maintain their own airway, if they cannot protect their own airway, if they're not ventilating or oxygenating well. Imagine a patient that you've got on BiPAP that's getting extremely fatigued. Maybe they're starting to nod and fall asleep. That could be an indication. The anticipated clinical course. So this would be a rare situation, I believe, or a rare indication for us, but it is possible. The scenario where this would be the case for us is if a patient has obvious signs of airway inhalation injury or airway burns, and we anticipate deterioration, and we're going to be proactive in securing that airway. Now, the last one is to facilitate safety. There could be a time, although I would argue it's going to be exceedingly rare, where we need to intubate someone to safely transport them. Based on our experience in giving ketamine to agitated patients, it's very safe. It's exceedingly rare for us to need to intubate that person after giving a dissociative dose ketamine, and the majority of the time, those patients wake up in the hospital, they return to baseline, and they're frequently discharged from the ER. So just because someone is agitated does not mean that they also have to be intubated. However, we have had a few cases where we give ketamine. There are other things wrong with this patient, and the patient was not breathing adequately after the administration of ketamine, and they chose to intubate. This is a situation where you would move forward with RSI, or in this case, maybe we could call it DSI. So here's just a few examples. The classic pre-hospital example is a patient with a severe traumatic brain injury. They have signs of a Cushing's triad. They are hypertensive, bradycardic. They have irregular respirations. Maybe if it's a patient that you expect them to deteriorate, we are ventilating with a BVM. Then generally, if we have to ventilate with a BVM, in most cases, an expertly performed RSI is probably better than ventilating them with a BVM on the way to the hospital. And then if a patient is altered, they're unconscious, and they have the potential for an airway compromise, or they're vomiting, they have a potential for aspiration, they have trismus, their jaw is clenched, they have an intact gag reflex. Historically, we would perform, or we would at least attempt, nasotracheal intubation, and we all know that is not always successful. It's most successful if we could go through the mouth, and now you will have that opportunity. Now, when we're talking about contraindications to RSI, we're not talking just about the patient where there's no indications. Here at Jessamine County EMS, our contraindications are going to be the inability to maintain an SpO2 greater than 92%. If we cannot get that SpO2 above that, then we have a shorter safe apnea period. So that patient is most certainly going to desaturate during our efforts at securing that endotracheal tube. So our requirement is, even if you're performing delayed sequence intubation, if you've got an agitated patient and you've sedated them, you've induced them with ketamine, and then you are providing that procedural sedation to oxygenate them, to pre-oxygenate them, and you attempt to get that SpO2 above 92%. If you can't, then you do not proceed with a paralytic. You might proceed with, something else. You might proceed with an iGel. You might just continue to proceed with BVM ventilation. But you do not proceed with administering a paralytic because, we've given the ketamine and, the risk isn't that great if we maintain airway patency and we're ventilating with a BVM because that patient is hopefully still breathing spontaneously. But when we throw a paralytic in the mix, it can go downhill rapidly and that patient can desaturate, brady down, and go into cardiac arrest. Second contraindication would be an inability to properly correct or optimize the patient's hemodynamics. So if the systolic's less than 90 or if the shock index is greater than 0.9. So what is a shock index? How do we calculate that? It is the systolic divided by the heart rate. So imagine if a patient has a heart rate of 100 and a systolic of 100, would that patient be a candidate for proceeding with RSI? No. So what do we do in that situation? Well, we resuscitate the patient. We attempt to get the systolic above 90 or 100, and your indication for actually using a vasopressor or using push-dose epi would be to get the systolic above 100. That is our goal. Our goal is to get the systolic above 100. Once we optimize that patient, then we can proceed, but not until then. Because if we don't do these things, then the benefit of performing RSI absolutely does not outweigh the risk of that patient decompensating. There could be patients with a pelvic fracture or with intra-abdominal hemorrhage that we're not going to be able to adequately resuscitate. The patient would need a central line with massive transfusion to be able to safely intubate that patient. Now, some have said, well, I've seen the hospital do it. Well, that doesn't mean that it's necessarily the right or the safest thing to do, and it's not what we're going to do. Okay, third, severe acidosis without the inability to properly resuscitate the patient prior to intubation. So imagine a patient with severe diabetic ketoacidosis that has a pH of, below 7, and they're severely acidotic, and they are compensating by breathing 30, 40, 50 times a minute. They're blowing off that CO2. Well, ketamine can induce apnea. It's not guaranteed that they're going to keep breathing during the apneic period. And then it's not guaranteed that they're going to keep breathing after we give ketamine. And then we're actually inducing apnea. So the patient is going to be paralyzed and we're not going to be able to ventilate while we're trying to intubate. So that CO2 can rapidly climb, the pH can lower even further, and the patient can decompensate and go into cardiac arrest. Now, lastly, if the procedure is unlikely to be successful, so we've looked at the physiologic criteria, there's also an anatomical assessment that you're going to need to perform on this patient before you attempt to intubate them. And we'll go over the anatomical criteria, but there's a lot of criteria listed here that isn't an absolute contraindication if you can improve and optimize your patient. Now, mnemonic to memorize, and you must memorize if you want to perform RSIs, the HOP mnemonic, HOP. Optimize hemodynamics, optimize oxygenation, and optimize the pH. So this slide is just to really make it stick when to not perform RSI or DSI or give a paralytic. This patient here, it would be difficult to optimize that patient. If they are hypoxic, it would be difficult to get a good seal on a BVM. It'd be very difficult to position them, and the airway's going to be more difficult to secure. So even if this patient is optimized hemodynamically, and their oxygen saturation is satisfactory, then they might still just be someone who's not a good candidate for pre-hospital RSI. So we really have to weigh the benefits and the risk. So the benefits are if we've got good airway anatomy, if we've got favorable physiologic parameters, if the patient needs it, and then we've covered the risk when there is a great risk. And you might be thinking, well, if the patient needs an airway, they need an airway. Well, that's not really true because, for the past however many years, we've managed the airway pretty adequately. We're trying to improve outcomes here, improve safety for the patient and for us, and reduce any adverse events. And we do that by selecting the appropriate patient, the appropriate time, and the appropriate procedure. And sometimes there are just certain procedures that are better performed with a team of 20 people around that patient in the OR with bronchoscopes and the ability to do a lot of different things that we cannot do. Now, a acronym that was coined, I think this was by Air Methods, but they have studied this and they came up with some criteria. They call it the HEAVEN criteria, HEAVEN being the acronym for patients that are high risk for this procedure. Of course, we've covered the hypoxemia, the extremes of size, so too big and too small, anatomically difficult. They have trauma to their airway, they have airway swelling, structural abnormalities with their airway, and then, of course, vomit, blood, fluid. And I'm going to say this, and I'll say it again, that always lead with suction when you're intubating anytime, but especially when you're given a paralytic and attempting to intubate. It's just not acceptable to miss an intubation attempt because you left the suction in the ambulance. Exsanguination, if you have severe anemia, hypovolemia, they can rapidly desaturate. And then, of course, if whatever is causing limited neck mobility or limited range of motion, if it's difficult to adequately position that patient. Now, if they're immobilized, there's emerging data that putting the patient in sniffing position, in proper ear-to-sternal notch position, does not increase the risk or the harm to a patient that has a potential spinal cord injury or unstable spinal column. And to go back to this, when we're performing RSI, if the patient has a cervical collar on it, then we pop it off. You can leave it on. You can hold manual inline stabilization if you choose and decide that you need to. And then after you secure the airway, you can put it back on.